Welcome to the April issue of the Journal of Vascular Surgery. We have 4 outstanding papers for you to read for free, as well as many other outstanding papers in this issue. The first paper, which is our editor's choice, is entitled "The Addition of Proximal Intervention to Carotid Endarterectomy Increases the Risk of Stroke and Death" by Wang and co-authors from the VQI study group. They address the impact of adding an ipsilateral proximal endovascular intervention, such as an innominate or common carotid stenting, to carotid endarterectomy for the treatment of tandem lesions in symptomatic and asymptomatic patients. The authors identified 440 patients out of 66,000 carotid endarterectomy procedures over a 14-year period who underwent the CEA plus a proximal procedure. They were more likely to be female, smokers, and to have had coronary artery disease, congestive heart failure, and COPD. Those with a carotid endarterectomy and a proximal procedure had higher rates of perioperative stroke at 3% versus 1.4% when CEA was done alone, as well as the combined 30-day stroke and death that was higher, 3.5% versus 1.8%. Symptomatic patients in particular had a significantly higher stroke rate of 5% versus 2%, and a stroke and death risk of 6% versus 2.5%. The predictors of stroke and death were diabetes, symptomatic status, and simultaneous tandem procedures. The authors concluded that combined procedures should be limited to symptomatic patients and, when required, should be staged. The next paper, "Impact of Proximal Seal Zone Length and Intramural Hematoma on Clinical Outcomes and Aortic Remodeling Following Thoracic Endovascular Aortic Repair for Aortic Dissections," by Dr. Kuo and authors from USC. They conducted a single institution retrospective study of 71 patients over 10 years who underwent TEVAR for acute and chronic type B aortic dissection. They addressed the adequacy of the proximal seal zone and its impact on retrograde dissection, the need for intervention, death, and aortic remodeling. Perioperative CT scanning was used to identify the primary entry tear, the dissection extent, the distances between the arch branches, and intramural hematoma involvement of the proximal seal zone. Indications for TEVAR included malperfusion, aneurysm, persistent pain, rupture, and uncontrolled hypertension. In 37% of patients, the proximal extent of the seal zone was without intramural hematoma, while 63% had a proximal seal zone entirely in hematoma. Review of arch anatomy revealed that to create a 2-centimeter landing zone of hematoma-free aorta, 44% of their patients would have required coverage of all 3 arch branches. In their series, 2 patients developed retrograde dissection requiring open repair, and 1 had sudden death. All 3 of these patients had a TEVAR with the proximal seal zone entirely in intramural hematoma. At 24 months, overall survival was 93%, and freedom from aortic-related mortality was 97%, while complete thoracic false lumen thrombosis was seen in 41%. The authors concluded that failure to achieve any hematoma-free proximal seal zone was associated with a higher incidence of retrograde dissection, but the length and quality of the proximal seal zone did not affect the subsequent aortic remodeling following TEVAR. The third paper for this month, "Gender-Related Outcomes After Open Repair of Descending Thoracic and Thoracoabdominal Aortic Aneurysms by Girardi and co-authors from Weill Cornell Medical Center examined the role of gender in thoracic aneurysms. Over 20 years, they identified 783 patients who underwent a distal thoracic or thoracoabdominal aortic aneurysm repair. Women were slightly older and had more chronic pulmonary disease, but operative mortality was not different between the females and males. However, females were more likely to require a tracheostomy after surgery, and female gender was an independent risk factor for major adverse events. Females also had slightly or significantly lower 5-year survival. The authors concluded that females had reduced preoperative pulmonary function, which may contribute to an increased risk for respiratory failure in the perioperative period. The final paper, Burnout, Depression, Perceived Stress, and Self-Efficacy in Vascular Surgery Trainees by Janko and Smeds from Cleveland and St. Louis, address factors associated with burnout in vascular surgery trainees. Those in the highest quartile of burnout were more likely to have moderate to severe depression at 40 to 4%, a higher perceived stress score with an odds ratio of 1.3, lower social support, lower self-efficacy, and were less likely to reconsider vascular surgery as a career. Those without a self-defined or identified mentor were significantly more likely to report burnout, and trainees with more frequent 80-hour workweek infractions and those without programmatic social events had higher levels of burnout. In contrast, trainees with the lowest quartile of burnout scores reported lower depression, lower stress, more social support, higher self-efficacy, and fewer workweek violations each month. And the lower burnout scores were associated with program mentorship, program-sponsored social events, and being more likely to choose vascular surgery again if given the chance. The highest burnout scores did not correlate with gender, age, marital status, proximity to their family, alcohol consumption, postgraduate year, number of prior program graduates, use of physician extenders in the program, or total debt. Similarly, there were no significant associations with these variables among trainees with the lowest quartile of burnout scores. The authors concluded that burnout in vascular surgery trainees is associated with higher levels of depression and perceived stress, and lower levels of social support and self-efficacy. The addition of programmatic social events, limiting 80-hour workweek violations, and the addition of formal mentoring programs may decrease levels of burnout. We hope you enjoy all of the papers in the April issue of the Journal of Vascular Surgery, and thank you for your attention.